Welcome, everybody. My name is Maria Bloyer, and I'm really lucky tonight to be here with Dr. Chioma Oruh. She's going to be talking with us about autism and the importance of early intervention and early identification. It's funny, I can usually say those two words just fine, but if we put them together, and they're always together for some reason, I mess it up every time. But I'm delighted to have Dr. Aru here. She is one of the gems in AJE's crown, and I'm thrilled to have a chance to talk to her about autism and the importance of early identification and intervention. So I'm going to throw it to her, let her lead this presentation, and I might jump in every now and then, with a quick question as we go along. So welcome.
Thank you, Maria. Very, very excited to talk about something that's very dear and personal to me. I'm Chioma Oruh. I am the Health Equity Project Director here at Advocates for Justice in Education. I also self-identify as neurodivergent, and my children are autistic, and we've gone through a lot of the steps, or almost every step, that we're going to talk about tonight as a family. So just want to lay the foundation first here, just talking about autism, and let's unpack what autism is. I really like this definition of autism from the Autistic Self-Advocacy Network. So shout out to Asan. And it's a long definition here, and that's why it's on the screen. So I'm just going to read some parts of this, which is that autism is a developmental disability that affects how we experience the world around us. There are many myths about autism, and that it can be harder for autistic adults, autistic girls, and autistic people of color to get diagnosed, mainly because the brand and a lot of the clinical tests, whether it's for the evaluations or different protocols of treatments, are typically done on middle-class white males, which is kind of the visual face of autism. So this is part of why it can be harder to see it, adult male children, to say that again, which is why it may be more difficult to identify autism in adults. There are people who get late diagnoses, in girls, and of course, people of color. Autistic people are in every community and, have always been, right? So even as the numbers today show that there is a prevalence of autism, many attribute that to just people documenting autism. But autism has been part of neurodiversity, or just how the human mind functions, for as long as we've been human. And autistic people are people of color, autistic people are immigrants, autistic people are part of every religion, every income level, every age group. Autistic people are women, are queer, are trans, non-binary, and any combination of these things. And there's no one way to be autistic, right? So some autistic people can speak verbally, some need other ways to communicate through devices, or other means of being able to convey their ideas. Some autistic people have intellectual disabilities, and some don't. And some autistic people need a lot of help in their day-to-day lives, and some only need a little bit of help. So there are low needs autistic people and high needs autistic people, which we will find in possibly every disability category. All of the autistic, all these people are autistic because there's no one right or wrong way to be autistic. So I think this is a great foundation as we start talking about early childhood development. And we're saying this in today's April 2nd, Autism Acceptance and Awareness Month. So it's also just general education here about the wonderful world of autism and the
And I
challenges
wouldn't
that come with that.
I wouldn't be doing my job if I didn't remind people that autism, the way you're talking about it, is a little bit different than what it is in the Part B special education world. That's where we have this unique definition that was defined and written by Congress, which is a little bit different than what we're hearing today. So I just kind of want to flag for folks that It is entirely possible to be a person with autism, to self-identify as an autistic person, to have a valid diagnosis, and then to show up at an IEP team meeting and find out that you may not qualify for an IEP as a person with autism. That is a thing that can happen. It's a little weird, and it doesn't happen very often, but because there are these kind of two different definitions, it does happen, and it doesn't mean someone is less autistic, or it doesn't mean that their identity is in any way, shape, or form in question, or their diagnosis is in question. It's just that in the special education context, under Part B, which is our school age kiddos, it's a little wonky. We have a whole webinar about that we can talk about later. But I just wanted to throw that out there early. I'll be quiet now for a little bit. Sorry.
No, these are important, and we'll get into some of that because eligibility is set at the state level, and there are different ideas. And actually, that's a perfect segue to this particular slide about what it means to treat autism, if that's the way we want to think about it, or manage, autistic symptoms that may not be as beneficial for the child or the person. And so these are part of why there are many different schools of thoughts and many different policies, and the ways that those policies are implemented, both in education and in healthcare, that explain or define or set parameters around who gets to be eligible for what. Um, but another foundation, so before we kind of get way into the weeds with this, another foundation, so we just said what autism is from a very, global, expansive view of autism as a condition. And then there's the concept of ableism, which, I would argue has a lot to do with some of the limitations that come with how we try to put autism in a specific box to fit specific ideas, right? That are rooted in one's ability to accomplish a task or ability to show up normal. So ableism is something that doesn't just impact autistic people, it truly impacts anybody. Anybody can be perceived to be less than or less able, and thus be a recipient of ableism. But specific to people with known disabilities like autism, I think this is a good way to unpack it. It's a definition that I got from Kennedy Krieger Institute, from a training model that they have called Becoming Anti-Ableist, kind of like becoming anti-racist, to play on that concept. And it says that ableism is a pervasive issue across society that inflicts harm on individuals with disabilities, ranging from stigma to health disparities. Ableism exists in a myriad of forms across all systems, at the individual level, at the community level, and at the societal level, which contributes to an underrepresentation of disability across education and training spaces. So just unpacking part of what this is saying when it says that we can see barriers across system functions. This article also introduces the 6 Ps to inclusive practices. And so it also helps to explain how ableism manifests at different levels. So on the micro level, at the granular level, there is the people in practice, just human beings. Human beings make laws. Laws don't make themselves. Human beings write policies. They don't write themselves. Human beings create diagnostic criteria and a whole bunch of wonderful things that human beings do, but they all come out of the human experience and starting with people. So right at that very foundational level, there can be barriers and solutions. But let's talk about the barriers. So with people in practice, ableism can impact, a lack of knowledge, right? Some people, like if you go into an IEP meeting, or if you say, hey, I just found out my kid is autistic, and you'd be surprised the number of people who may never have had to, go, provide IEP, have an IEP meeting with a parent with a new diagnosis, or, education can be in a formal setting, it can be in an informal setting. But what people know about autism, or any condition that is impacting how they feel about that condition, it defines how they interact, how they respond, how they emotionally engage with one saying that they are autistic or introducing that into any kind of conversation. And that triggers implicit biases. So implicit meaning it's not conscious, it's not happening on the conscious level. And it's not just with people, it's also the things that people do. So people are the person who picks up the phone to make your appointment. They're going to respond based on what they know and how they feel, and that's going to trigger both explicit, maybe potentially explicit biases, or implicit biases. So with autism, it could be, somebody talking louder because they're like assuming that you're deaf, and not that talking louder is even going to be helpful for an actual deaf or hard of hearing person, but people start interacting with you differently just based on their level of knowledge, and it's a possibility, right? And it may be happening subconsciously. On the policy level, so on the middle level of things, there's the societal, how society kind of engages with it. And it's kind of middle of the ground, where places that we go, programs that we go to, like school or a hospital or a clinic or, wherever we get our services, these can be places and barriers to where ableism kind of shows up, ableism against autistic people, ableism against any person with a disability. It kind of exposes a lack of access, right? It can manifest in that, again, as Maria just kind of introduced, don't be surprised if you're going on an autism journey for yourself or your child, and it's a new discovery, yet access to the things that you need to be able to help, like speech therapy, occupational therapy, even, just regular behavioral therapeutic interventions, which we'll go through some of the ones that are specific to autism, can be hard to access based on your insurance, your income, your access to insurance or your lack thereof, your access to resources, your geography can impact. These are societal barriers. Policies that strip people away of their autonomy. So there's certain things that you may be automatically excluded from, and that's part of why we at AJE do what we do to make sure that some of these barriers, we can question them, we can probe based on the letter of the law and the policies at hand to help push back against some of these societal limitations and barriers. On the macro level, on the grand scale, there are at the community, on the greater community level, there are policies and the ideas behind policies, which we can think of as philosophy, and which are just ideas, right? How people formulate ideas and how those ideas impact what they do and how they move, right? So we start with people and places and how we create the rules to how we interact as people in places, right? So at the community level, some of the challenges with ableism is that it can be, policies can create inaccessibility, which is why we have laws like the Americans with Disabilities Act that says, hey, people need a reasonable accommodation that you should be able to be afforded, especially in public spaces, to be able to get up a ramp or have access to whatever would make it accessible or easier for you, because there are lots of inaccessible things. For autism, it may or may not be a ramp that you may need. There are many different ways to accommodate people that are autistic, including making things light friendly, sound friendly, sensory friendly is a big part. You'll notice there places like the Kennedy Center that will have sensory friendly shows. Those are considered autistic accommodations, and they arrange like visual aids So there are many ways to create accessibility in inaccessible places. And this is why policies, local, federal, are extremely important to addressing ableism. But unfortunately, it can work the other way. Policies can reinforce ableism. Policies can reinforce exclusionary practices or inaccessibility, which is why they change over time. And it comes based on the ideas of how we think about things, how we think about rules, how we think about rules that should guide what people do and where they do them, such as the medical model on disability. So for the rest of this training, we're going to be talking heavily about autism within the context of the medical model. And just to explain what this means, there are different mental models and different ways that we think about things. It's called a model because it's kind of a way of thinking that has a structure and a system function. The medical system, right, starts with the idea of a medical environment and a scientific approach to solving human conditions that require treatment. In many ways, autism has a social and community impact that stretches beyond the medical model, which says that things should be treated or fixed. Organizations like ASAN and disability advocates also try to push the barrier and the thin line between solving a problem scientifically, or you can't solve everything with a pill. You can't solve everything just with a therapy protocol. That some things are just the way people are, and so it should work both ways. And the medical model kind of struggles with that. And at the same time, that medical model is critical for providing the support and the services that autistic people, especially high needs autistic people, need to be able to have access to the world. So there are many ways to think about it. There are many ways to apply these things, and they can be barriers as well as they can be, they can alleviate barriers. So that's a lot, and we can unpack during Q&A. But these are important foundations when we're talking about autism. As I mentioned, my role here at AJE is as the Health Equity Project Director, equity being our philosophical foundation. And we are in Autism Acceptance Month, right? So I just want to lay another last foundation. So we've laid the foundation of what autism is, some of the challenges that autistic people face when it comes to ableism, and truly any disabled person. And as I mentioned, anyone can be perceived. So thus anyone can be a victim of ableism. But in terms of solving some of these issues or addressing them during Autism Acceptance and Awareness Month, there are, again, different approaches. So these are just basic ideas, and people are asking for equality. And so this is just an example of, everyone getting the same shirt, that we should require people to have equal access to different things, right? That's an aspiration. Diversity is another aspiration, which is everyone getting a different shirt, for example, right? That there are many different kinds of shirts, and for many different reasons, people like blue, purple, yellow, or whatever. Belonging is a concept that's thinking about wearing the shirt that you want without being judged. You may want to wear it backwards. You may want to rip it up, and that should be okay. And just kind of how we're showing up in the world. And acceptance in Autism Acceptance Month is understanding that people wear just different shirts, and that it's okay that people are just differently wearing shirts, and some people maybe not wear a shirt at all and just be walking around naked, right? That is part of accepting, to be able to accept diversity, right? But and then there's the concept of equity, that everyone gets a shirt that fits them. And it is from this perspective that my work here kind of leads, and our work here at AJE really embodies that with autism and any disability category that we are supporting a family or a child or a youth, that we're coming, that there's not one size fits all, right? That people need different things, and it's okay, especially within the parameters of the law and policies, and autism and autistic people and parents with young children with autism are no different, and that everyone has a right to be able to approach things for what fits them in their life.
So I was going to say, and now we get to talk about all the different ways early intervention can do that.
Yes.
Yay! So what exactly is this whole early intervention thing that we told people we talk about?
Okay, so early intervention, again, there are different approaches. It is an optional when it comes to the policies of early intervention, like all things special education, you can opt out or you can opt in, but hopefully by the end of this training that we can sell those who may be just starting their journey and try to figure out the best next step. Again, I've been there personally, and sometimes it's not presented as options, but I do want to and there are ways to personalize even with existing options. But before we get into all of the nuances of that, what is early intervention, right? It is a term that is used to describe services and supports that are available to babies and children with developmental delays and disabilities and their families, right? It may include the interventions of early intervention, typically include speech therapy, physical therapy, and other kinds of services in the home and in community spaces. For early childhood intervention, it can be in the home, whereas when you grow out of the early childhood for special education, it can only be in the school. So that's another key difference with early intervention.
So
And
the early intervention, just to interrupt you, early intervention applies to kids, little guys, infants and toddlers, and that's got a really specific term. That's a really specific age, right? So that's 0 to 3.
yeah,
And
with
and
some
the
extension to 4, depending
right,
on an individual basis, that can be the
right.
term.
If you sign up for the end of it, the extended option in DC, which is really unique,
Yes.
you can opt into a later program. And then the student is served typically at home, right? But the legal standard is the natural environment. So it can be also home or daycare or grandma's house, whatever that looks like. Am I right on that?
Exactly, home and community, right? And that's a unique feature to just that population that you mentioned from birth to 3 years old, and with the option to extend to 4, and one has to be eligible for that extension up to 4 for early childhood intervention. Now, there is the concept of prevention and early intervention in the behavioral health space, and that's a little different. We're talking specifically here about early childhood interventions. But truly, an early intervention in general is any time that you intervene before the problem becomes acute. And that is the concept behind getting an early diagnosis in life in early childhood. And programs are available in every state and territory per the Individuals with Disabilities Education Act, Part C of the Individuals with Disabilities Education Act. And these are publicly funded programs that are free once you're eligible, are free or at a reduced cost. Some states do create programs that some of it is free and some of it is insurance billable. In the District of Columbia, all of it is on the public trust. So once a child is found eligible, and our eligibility and the management division that supports the early intervention program for DC is called Strong Start, and that is out of the Office of the State Superintendent of Education. On the slide, you'll have their number and their website, OSSI, and I'll get into the steps of eligibility. But it's free to families, and there's no co-insurance in the District of Columbia. And so we are privileged to be one of the states that makes it fully covered by the state. Now, determining eligibility for early intervention is, again, these are parts of, that ableist framework that it's down to policies. As I think we mentioned in the last slide, that eligibility is, or much of the difference, right? Extending up to 4 years old, whether it's fully paid for by the state or not, and then determining who gets to be eligible. These are all things that are decided at the state level, even though the law that governs this is federal. And so early intervention is intended for infants and toddlers, again, who have developmental delays and disabilities, right? And it doesn't require you to be autistic alone, or even have an autism diagnosis, even with autism symptoms. It just requires that you meet the eligibility standards based on evaluations that look at the domains of development, and we're going to talk about that. So some children, in terms of eligibility, some are identified from birth because their experience started in the NICU, right? So they may have been born premature, or they may have been a birth trauma that required hospitalization. And so that child and that baby is being identified right out the gate in life, and that's a place and a stage that eligibility is determined. For others, and this was my family's story, it may happen later. It may happen, you may have had a quote unquote normal birthing experience, or your child is showing development, not showing typical development signs. And then all of a sudden, you begin to notice different peculiarities, and they show up typically around between 6 months and 18 months, which are what the evidence-based studies show are the most important times. And this is part of where we see disparities. We see that low-income families, Black families, brown families, Latino families, immigrant families typically get diagnosed at a later stage in life, which is delaying the amount of time that one can begin to receive early intervention. So it can happen right at birth, especially if your journey starts in the NICU or through some kind of trauma birth, or it can start later after you speak to your pediatrician or nurse practitioner, whoever your primary provider is, to help later, 6 months, 18 months, 2 years, 5 years, 50. There are people getting diagnosed later, right? So then that it's no longer early intervention, then it's something else. But it can happen later in life in terms of where one is identified.
Right. And there's some
Um,
early diagnoses, right? That some families are presumptively eligible for early intervention. I know we're going to talk about that right there at step one. But I just wanted to remind folks that, if you have one of the newborn screening tests at the hospital may identify like a chromosomal difference in your child that may automatically make them eligible. Um,
Yes.
or just having
Genetic
just
testing typically comes, during the post-diet screen, after you've been screened and you've done a visual test. Like maybe there's some hospitals that are now doing those genetic testings right away, but it's usually if there's already a pre-existing condition or a suspicion, like again, if the child comes in with birth complications. But on average, when you birth, unless there's something that predisposes you to requiring those screenings or genetic testings, they're not going to happen right at birth. They're going to happen sometime later once you have been screened and through some kind of evaluative process. There are different screening tools that they use, like the ASQ or the MCHAT or the GARS. There are many different evidence-based evaluations, and then one can start a battery of genetic testing to understand the root cause. To be clear, there is no solution, there's no cure from the medical model for autism. There is no one treatment protocol, and then people would need different things. So there's not really what genetic testing would do anyways, even if you found out through genetic testing. And there are many ways that one is autistic. You may be autistic, but not Fragile X or any of the other ways that show up in a genetic test. But these are all things to help one understand how you can approach your individualized treatment process. And yes, it can start sooner, it can start later. And of course, best what I would love to see. I'm part of the school of thought that definitely believes that the sooner that these things happen, I wish hospitals were were offering genetic tests to every birthing person, but that's just not happening. So step
So
one.
I was more thinking of the heel sticks, that standard battery for metabolic screens where we catch a lot of things. But let's because we're running a little low on time. Let's do step one, which is the referral, which we just kind of talked a little bit about, right?
Yes.
Because there's two ways families can get referred. They can get referred through a diagnosis or a medical experience at birth or around birth, and then some people come in through, some concerns that may have developed later, right? And then what happens after that referral?
Yes. Okay. So I think the referral, because child find is a big issue here in DC. Just to know that in the referral stage, truly any caregiver, and that is the person at the daycare, that's the social worker at the center, that's the nurse that does the home visits, that's the parent themselves, that's the doctor, community member that is intimately involved, that's the doula. Anyone can be a referral source to say that this child, any authority in this child's life can be a referral source. Now, receiving services or even taking a step to be evaluated is something that is in the domain of the legal guardian and the parent, right? Whether they made the referral or not. So there are many ways. So, one should be vigilant. It takes a village to be able to help with the identification part. But once that happens, and one can submit that referral by calling this number here, the 202-727-3665, or by visiting the early intervention website on eip.osce.dc.gov, and you can fill out the referral form online, or you can call it in. Step two, after a referral has been made, a Strong Start specialist will follow up with the family, again, to explain, just how it works, which the next step after the referral has been made is that they do a screening, right? Explain more about early intervention, answer questions, and then they schedule for an evaluation. And sometimes the screening has happened. Sometimes, one has taken an ASQ exam at their Head Start program, and that was part of how they were like, okay, now we're going to refer. Now I'm going to refer my child, or I'm going to refer this family. The evaluation is conducted by a specialist that works for early intervention or is contracted by early intervention, and they will assess 5 domains of development. And we're going to talk about those 5 domains. Determine eligibility is step 3. So after they evaluate, and it can be an arduous day-long process because they're literally poking and prodding at the little person in a safe, friendly environment, but it can take many hours. But step 3 is then determining eligibility. And if the child has a 25% delay in one or more areas, I think in DC, it is one or more areas. Every state kind of sets it differently. This is DC's criteria here. Children who have been diagnosed with physical and mental conditions that have a high probability resulting in a developmental delay or disability then qualify for early intervention based on meeting this 25% delay in one or multiple of these domains of development that we're going to go over in just a second. And then step 4, once they are found eligible, should they have met that criteria, then the family begins to work closely with Strong Start to create what is called the Individualized Family Services Plan, the IFSP, which is different from the school age special education process, which is the Individualized Education Program, which is called the IEP. And it defines the goals of the child and services and support to reach the goals. Again, the difference between IFSP and IEP is the IFSP can happen in the home. It can be delivered in a center-based. Their location of services are a little bit more expansive, and they are family-centered versus student-centered. So because babies and little people typically cannot advocate for themselves, it's heavily dependent on the caregiver to be able to articulate the needs and to be able to support with measuring of the growth. So the family is very much involved in ways that are not as intimate in the school for school age children that receive special education. So if the evaluation finds that a child is ineligible, then the family can still participate in Strong Start. And they can, so Strong Start has these community-based programming that happen at libraries and rec centers and other partners that they work with. And so there's still an avenue, even if one is determined ineligible. And by saying you're ineligible for Strong Start does not mean you don't have autism, does not mean you don't have a disability. It just means that you do not meet the criteria for services. And again, you can retest, you can seek eligibility. Again, we have due process rights as well in this domain to make sure that there's fair and equal access. And there are ways that one can ask for a reevaluation. But the domains of development the criteria are developed. So it says our DC's policy is that there is a 25% delay, which would mean that they would have significant delay in at least one of these 5 developmental categories. So when they're doing an evaluation that takes all day and that can be very arduous, is they're looking at the child's cognitive skills, right? The child's ability to think, react, and learn about the world around them. So things like engaging the child in dialogue and watching the child be able to explain what games they're playing in or what they're doing, or, it will look different for an infant than a toddler, for example. Communication, your child's ability to exchange information, right? Using expressive language, and also one's ability to receive information using receptive language. Those will be tested. Again, that looks different per child. And in the concept of accommodations, this can be provided in different languages. For example, when my children were being evaluated, they had a person, I'm Nigerian, they had somebody in our native language, Igbo, because my toddler was spending all his time with my non-English speaking grandmother. So they wanted to rule out that his ability to understand language wasn't just based on access to English. And that does require advocacy. You have to ask for these things. And so parental education and your ability to also make it accessible is extremely important to make this process as fair as possible. Other domains are in terms of oral motor articulation, one's ability to actually use their motor skills to be able to use the word. Are your jaws, are your lips, there are other ways to assess communication, especially in an infant, for example, who may not be speaking already, so you're not actually checking for their spoken language or expressive language. Other domain here is social emotional, a child's ability to interact with others and to self-regulate and organize their emotions, right? They look at child's ability to play, to interact. We find with a lot of autistic children that, They can be another symptom of autism could be parallel playing, like not actually playing with somebody, but like playing around somebody and being resistant to interacting. Those can be signs of a child that's in need of social emotional support. Interpersonal relationship. Is that child receptive to another person's another person in their specific space, immediate space, and what kind of behaviors come out of that. They observe for those things. Adaptive skills is your child's ability to adapt to different changes. Transitioning from one activity to another activity, from one location to another location. This is a big deal for autism and autism adjacent folks like myself that are neurodivergent. Being able to transition and make changes is a very big sign. It's a telltale sign of one's ability, and they test for that. And the last domain that they test for is physical, right? There's a hearing screening, a vision screening, looking at your ability to do fine motor things like throw a ball and, I don't know, fold a paper up or anything you can do with your hands. And then your fine motor skills, like being able to tie a shoelace or write something down, right? And there are other domains that, they would test in terms of your physical ability, your reflexes, your ability to grasp. I mean, again, it really is age specific, right? What they would do for a 1-year-old is different than what they're going to do for a 2.5-year-old or a 3-year-old. And 3-year-old is the cutoff time. Once it's actually 2 years, 10 months is the cutoff for evaluation age for early intervention. So anyone that's doing an evaluation after the age of 2 years, 10 months is really testing for the other part B of special education. So there are many benefits to early intervention, right? And some of, the things that, I've been able to kind of identify on the CDC's website and others is that they improved communication skills, right? Like studies show that children with speech delays that receive early intervention typically have a better chance at developing their speech skills. And so it could be one of the quickest way that we can see how early intervention can impact a child. But it's not the only way, and it may not be the way, because again, everyone is autistic for different reasons. And just because you had early intervention and now you're not, being able to give a speech, it doesn't mean it didn't help with other important things like increased social interaction, building friendships, increased ability to integrate into an academic environment and perform better. These are things that evidence has shown that early intervention has given young children that have had access to these services, a better winning edge. Their educational outcomes are better than children that don't get these services, along with the social and communication benefits. So here are a few examples of interventions that help in early intervention and honestly throughout the lifespan. But the earlier, again, the more that we're able to see how these interventions really can shape and take a child from one trajectory to another trajectory. Applied behavioral analysis. So now there are people within the autism advocacy space that do not like applied behavioral analysis. But from a cultural lens, there are different reasons why it is the most acceptable through through billing, insurance billing, and the like. But it's widely used. It's a widely used behavioral protocol that can be used at any stage and age, but it's primarily most effective in early childhood, that focuses on teaching and modifying behaviors through a reinforcement model that is hopefully humane. And that's part of why some people do not like ABA, because there are inhumane ways to apply it, but there are many humane ways to apply it. So occupational therapy addresses sensory and motor challenges, right? Being able to use functional tools to be able to measure one's motor skills. Speech therapy, focusing on one's verbal, nonverbal, receptive language and social communications. Floor time, which is adjacent to ABA and other kinds of therapy protocols. It's a type of play therapy that is, I would say for my children, floor time was extremely important in creating and what I consider an unbreakable bond between me and my children, because that skill set to just get down to a child's level and interact with them where they are, it to me in my family has been the most important thing. And when that bond is made, it completely impacts their behaviors and their abilities to feel that there are people in their lives that get them and that understand them. And then they're the picture exchange communication systems, which are assistive technologies, or PECs, and they are augmentative alternative communication methods that are used, on an iPad or other type of, visual communication tools to help with language. Because some people are just going to be nonverbal, and that's okay. And then there are communication tools like the PECs and other assistive technologies that can help with that. And there can be assistive technologies for all these other things, occupational therapy, and well, not floor time, but maybe at some point. Um,
Chioma, I wanted to, before we left that topic, I just wanted to remind families that in DC, our early intervention program, is run through Strong Start, and they use a coaching model. So it is really going to be, folks helping families do these things. You may have a speech therapist who you consult with, um, but you might not have a speech therapist that your child meets with every week, and an occupational therapist that your child meets with every week, and an ABA person. This is all going to be integrated into a model of coaching and intervention that is designed to be family-centered and stable, and minimize the number of professionals in and out of the family's lives. So I just wanted to flag that your child might be getting an early intervention around speech, but because, their primary needs are around occupational therapy and physicality and movement, you might work with an occupational therapist primarily, and that's okay. Early intervention, again, is very child-centric, very family-centric. So I just didn't want
very
people to read
individualized.
this and panic and go, oh my gosh, I'm gonna have 27 professionals. You're not, especially in DC, where I think they've really embraced that best practice of a coaching model. So
Yeah, and and it's individualized, right? Like there's one, and that person is typically a case manager. So I do have a certificate in early intervention, and it is a best practice to have that trusted partner. And that trusted partner can have many different kinds, they again, as Maria said, they can be an OT, an occupational therapist, but as long as they are your case manager, what they're really doing and what their role is in your life is to really help in accessing all the services, whether it's OT or not. And a big approach to early intervention that I think it's different than the school-aged interventions that they do in early childhood is that it's really grounded around routines-based interventions. What your coach or what your interventionist, your early interventionist can help you do is create those routines based on the supports and services that you have access to that help you thrive as the parent. Because again, that's not going to happen when you go to school, right? They're going to completely ignore you and you as the parent and your needs. But in early childhood, it's perfectly encouraged. It's actually a big part of the job, how you can create those safe routines when you don't have direct services, because that's going to make all the difference in the world for the impacts of early intervention for any of these protocols that are listed here. Why is family involvement crucial? Well, part of why Part C of the IDEA that supports early childhood intervention, part of that understanding comes out of experience and knowing that family involvement prior to the 1970s, when people who were children like Joy Evans, which is somebody whose name in DC people know, if you remove a child from the home at a very young age, it may or it will it has shown over time, we've had to learn as human beings that has more detrimental impact to the child's development, even as they may be getting more clinical interactions. So families have been proven to be extremely important to be able to support a child that is going through developmental challenges, preferably in their home space. But there are many, it's individualized, so there are many different things going on. For autism specifically, family involvement can significantly enhance a child's developmental development and well-being, right? Because bonding is a big part. And as I mentioned, that floor time helps with that, so that there's comfortability to improve communication, social, and overall quality of life. So benefits to the child, these are some of the things I've found, on CDC and online, is that the child can have that comfortable environment to improve their social and communication skills. It reduces disruptive behaviors because children are learning to bond with their primary caregivers. It increases independence because families, can create a cultural approach to how one can show up in their treatment and services. It can overall increase academic success, long-term symptoms can reduce, and just increase quality of life. For the family, for the caregiver, it can strengthen the family's relationship, and I can testify to that. It can reduce stress for the caregiver stress, because now there are all these other people that are around helping to carry the heavy load of a young autistic child. It can improve coping skills because, again, part of the routines-based mentality is that once you set a routine, your ability to kind of sustain yourself becomes different. You're measuring it's a marathon, not a sprint, right? And it helps one understand that they're an anchor. And once you become an anchor for a young child, you'll be an anchor for your teenager too. So it's a practice that really has extreme social benefit. So I hope this has sold people on the concept of early intervention here. I don't know if there are any other questions, Maria, if you or any other participants want to ask, but you can also reach out to us here at AJE. Should you want to receive a little bit more understanding of what we just covered here, or if you want us to support through the process of obtaining evaluations or walking through the steps of becoming eligible for early intervention. And this is our information. We're located at 1200 G Street Northwest. Our number is 202-678-8060. You can check us out on our website. You can also, fill out an intake on our website at aje-dc.org. And we also do have one of our, champion veteran staff that is also located at Mary Center a couple of days of the week, and that's the Georgia Avenue Mary Center at 3912 Georgia Avenue, between 9 a.m. and 1 p.m. on Mondays, one day a week. So thank you for this, and if there are any questions, we will take them.
Right. I am, though, going to pause the recording now, but thank you very much, Dr. Aru, for being with us today and chatting with us, and bringing your, as always, macro understanding to the micro issues. I really appreciate it. But thank you again. And when we post this, we'll put all of the resources and links that we mentioned in the comments so folks can see them there. Okay, thank you again.
Thank you.
Oh, wow.